I'm Kelly, and we are so proud and thankful to be invited to present to you all the work that you all do on behalf of the Ambassadors on Call, supporting Texas Children's and the many missions is just so wonderful, and we appreciate everything you do. I see maybe a couple of familiar faces in the group that might have been in the Simulation Center before, right, Janice? She was practically an employee here for a while, every Thursday. So good to see you again. How many of the rest of you have ever been in the Sim Center in simulation before? Right, I saw a few of you. So the most of you, this is your first time here. So we're really excited and proud to show off the Simulation Center here at Texas Children's Hospital. It's really been a pleasure to partner with Dr. Doughty and our hospital leadership to build and continue to grow such an innovative manner of education and learning for patient safety and quality improvement at Texas Children's Hospital. So I'll go over a little bit about our team. I mentioned that the Simulation Center is one of our key quality improvement and patient safety strategies at Texas Children's Hospital. We actually, although many of you may know of simulation as an education-based modality. For example, if any of you are clinical in any way and you went to college, nursing school, medical school, we had skills labs and simulation where we practice things like that. So it was a training kind of a modality. But the phenomenon in the last decade or so has been that hospitals have been starting to recognize the value of supporting a simulation center like this one and or simulation strategies, because it allows hospitals to get at something very elusive, what has been very elusive, and that's decreasing harm to patients, decreasing medical errors, improving teamwork, improving communication. Simulation is uniquely equipped to train people in things that you can't learn in a skills lab. You've got to do it in teams with people. And then it's also a way to, let's make the errors and the mistakes in simulation and figure out what are all of those factors that lead to mistakes so that we can eliminate them in real life. Back in the day, when I was a nurse in the ICU and came out, all I had was simulation in nursing schools. So I had to learn in the ICUs by practicing basically on patients and on my teammates how to give safe care, prevent mistakes, how to communicate well. And so now it's such a pleasure to see that we've come so far that we have this wonderful facility and the methodologies that we're using for simulation to help move the needle on some of these elusive patient quality initiatives. So I have the pleasure of leading a team of not only the Simulation Center, but also immersive quality improvement and patient safety education curriculums. We have an advanced quality improvement course. The Simulation Center, though, is just our key tool in the box to really get at some critical patient safety needs. We are a team, a small but mighty team here in the Simulation Center, and it's my honor to co-lead with Dr. Doughty as our medical director and Royanne Lichleiter, who is the assistant director for the Simulation Center. Just really visionary, wonderful, talented, creative people. We have, in addition to Dr. Doughty, we have, as our simulation program has grown, we're now not only, even though you're here in the medical center, in this simulation center, we have expanded across the system at Texas Children's to the Woodlands, to West. We've started to develop subspecialties, OB-GYN, surgery, anesthesia, and so we've added 6 associate medical directors that help us lead our medical simulation initiatives. We have 5 education specialists, and the simulation expertise is not something that you just kind of find on every street corner. These are, it's a growing professional community of expertise, and so they have they're not only educators, but they specialize in the use of simulation, an immersive experiential methodology that's constantly being innovated as we develop the science. So these are incredible people, and you will see many of them as you immerse yourselves in our Simulation Center settings today. And then our support team of systems, analytics, and operation. technical support. You will notice once we talk with you and show you pictures on the slides, as well as you're moving around the simulation center, we've got some pretty high-tech equipment around here. Pretty fancy kind of robotic equipment and AV systems and recording, and that takes a very specialized set of expertise to run all of that. The makeup that we apply to the mannequins to make it look like you're at the scene of a trauma accident. So that comes from this team here. Just a little bit of background. Right now you're in our Central Simulation Center. It's one of the largest pediatric focused simulation centers, although we have grown beyond just this simulation center to also having satellite spaces in some of our other campuses, West Campus, Woodlands, and the Pavilion for Women. We do a lot of simulation here in the simulation center, but we also have a growing program that is called in situ simulation, which is Latin, the Latin word for in the setting. So we take simulation out to the units, and we're actually doing simulation on the patient care units, sometimes by surprise, to allow teams to practice that surprise factor. Like, that's what happens in emergencies, right? You don't plan emergencies. What simulation offers us the opportunity to do is to help people practice being in a stressful situation that they haven't planned for, and learn how each of us behave in that stressful situation. So you'll hear more about our in situ settings. And then our overall activity, we generally just, because everybody likes numbers around TCH, especially if they're big and especially if they're growing bigger, right? So overall activity, we do almost 700 simulation sessions in the course of a year. We run almost 7,000 learners through programs, learner encounters, and you see some of the numbers here. We're a very busy program, one of the busiest by a lot of the simulation standards for hospital-based simulation centers. You'll see a little bit more up close and personal as you take your tours, but we have, let's see, we have 6, 7, 8, 9 simulation theaters. We call them theaters. Some are smaller, some are larger. All of our simulation theaters, they're like little sound stages, recording stages, TV studios, where, as you'll note, even in this room, we have recording going on. We have a camera in the ceiling, and we have microphones that if we were doing a simulation using you all as participants, we'd be able to record how you all are doing in simulation. So that's kind of part of the element of simulation that really immerses, that's one of the big learning benefits to simulation. The recording of what's, not only just the practicing of what's going on, but then the recording afterwards. So you can look back and see what went right, what went wrong, how can we do better.
I'd just like to reassure everyone that we are not recording you.
Yeah. We want to see what each of you selected for your lunch. So we'll review that later and report that on our outcome data for the simulation center. And this shows you those nice big numbers that are growing bigger and bigger every year at Texas Children's. This gives you an idea of when we started, which was, we're coming up actually on our 9th anniversary of the grand opening in 2009. And so we've just had exponential growth each year because it's really caught on in a lot of different ways that you'll hear about. Wanting to also make the point that we started off being interprofessional right from the beginning. We weren't a nursing-based simulation center or an anesthesia-based or an ER-based simulation center. Right from the beginning, the hospital identified that we really need to focus on interprofessional training, getting all the nurses who went separately to nursing school, the physicians who went separately to medical school, the respiratory therapists who went separately to respiratory therapy school. We wanted them to get together in the real site and learn how to communicate and better together and what each other's role is in managing high risk, high stakes situations. So we've been interprofessional from the beginning, and as you can see, a really exciting factor that we're growing now is our other population. And so what other is people like you, people that are not necessarily our providers here at the hospital, but they're people in the community who are learning. For example, parents who are taking their infants home with trachs or on ventilator dependence, they're participating in how to manage emergencies with their infants at home now. Our firefighters, many of you have heard about our PD Steps program. Parents are participating. Our family advisory group are participating in SIMS. So we're really excited to get out into the community beyond the clinical providers. And I mentioned before our growing in situ SIM as well as in the center SIM. So that gives you those numbers. So I've been talking SIM. What is healthcare simulation? And so this is the official definition of it. But basically it is a technique, a methodology, whether it's a method or it's the setting we put you in, but we are trying to recreate as well and in as high a fidelity as we can the sights, sounds, smells, textures, touches, stressed pulse, racing pulse, heartbeats, feel of a real situation. And so that's the goal of our high fidelity and our low fidelity simulations. We use mannequins. We have wonderful mannequins that their pupils can dilate, they can turn blue, they can bleed, you can feel pulses and all. But it's not just about the mannequins. It's about the whole scenario that we've created to immerse our participants in that creates time urgency, stress urgency, and the look and feel as well as just the plastic mannequins that you'll see. Basic elements of a simulation, the scenario itself. Our team and our simulation instructors are trained in actually creating a script and a scenario, just like on a TV show, or they create a plot that they will insert the participants in. The simulator is either the mannequin that I mentioned, or it can be the physical space. It can be an ambulance simulated. It can be an MRI setup. And it can be a new set of ICU rooms at the Legacy Tower, right? That we simulated in a warehouse over off El Rio. Was it El Rio? So it's such exciting creative work to kind of put this together around what the needs of the particular team is that's doing the simulation. Main thing is the experience. This is experiential learning. This isn't reading articles, listening to lectures. This is you, our team members, whomever is in the simulation that is feeling their pulses race and feeling what it feels like in that situation. And then we debrief afterwards. We record, most of the time we'll record the simulation, and then a skilled debriefer will debrief afterward in a room using the video as an adjunct, and you'll see some of those techniques. Different types of medical simulation, again, you'll see different examples here. High fidelity simulation is generally what we think of with the high-tech mannequins, with rooms and theaters, teams working together. It's very much like the real ICU unit or the real operating room when they're in there and they're trying to manage an emergency. We're recording it, we're debriefing it. But we can also do really effective training with low fidelity simulation, like just procedural, an arm to start IVs in, or a tabletop simulation where we're just talking through a workflow. Hybrid simulation combines several different kinds of simulation, most often probably the use of standardized patients who are our actors and actresses that we use to play the roles of parents or other, sometimes providers in a scenario, again, to amp up that emotion, that stress, that experiential factor, and they're scripted as well. And then virtual reality and some of these other high-tech types of simulation are growing. And I've alluded to this a bit along the way, but the benefits of simulation. Why put $2 to $3 million into the building of a simulation center and the training? Big ticket item for a hospital, but so worth it if we can move the needle on improving patient safety. You get the chance, unlimited exposure to high-risk events, rather than just every 2 years or so, something might happen, and you've got to think about that and know what to do, but you never get the chance to practice it until it really happens. So we get to practice that over and over and over again with our simulations. Creating a safe atmosphere for training so people can make mistakes And we want them to, because that's how we learn. Y'all probably remember, if you make a really important mistake, it catches your attention and you never make that mistake again, hopefully. So that's part of the experience of simulation. Unlimited practice, hands-on training, relevant to the practice. You're immersed, you're not reading journals or watching videos. And then outcomes that are difficult to teach or assess by conventional education, so particularly teamwork and communication. So we have come a long way. We've got the technology, the different kinds of mannequins that you'll see. We've got different kinds of settings, the simulation center that you'll see with a control room, and then the actual patient care units. The methods of simulation, from tabletop simulations, planning what unit to put on what floor of Legacy Tower was what we were doing here before we built the warehouse. Use of standardized patients or actors to help providers learn communication skills, or full-on high-fidelity simulation. And then systems integration, which we'll spend a lot of the rest of the time talking about, where it's not just education. It is, we do simulation for competency and assessment. We do use simulation for research and development of medical devices, as well as development of new simulators. Advocacy, some of the things like we're doing right now, advocating within the community and interested people to get the word out about the benefits of healthcare simulation and how it's driving improved patient care and patient safety at Texas Children's. And then quality and patient safety initiatives, simulation that's tied directly with a quality and patient safety initiative. And these are just some examples of each one of those 5 arms of the kinds of courses and different kinds of things that we do. And Cara will talk a little bit more about this in the next part of our presentation. So our vision is integrating healthcare simulation and quality safety education, providing continuous learning all along the way, whether you're a new grad or you're a seasoned attending physician that hasn't been to school in over 20 years or so. We want everybody participating in simulation. And I'll turn it over to Dr. Doughty now to continue giving you some specific examples.
Awesome. All right. Well, I'm excited to get to give you, after Kelly's background, sort of laying the foundation, I want to talk to you about some specific examples of simulation. As she mentioned, we do a ton of simulation predominantly for educational purposes, for teamwork, communication, medical knowledge, for all of our providers, and that happens both in the center and on in situ areas throughout the hospital. I want to highlight a couple of programs that are unique, that aren't sort of our routine simulation, but instead sort of go above and beyond. And the first couple are about really how we teach teamwork and communication and human factors. So healthcare needs more opportunities for practicing teamwork, right? We all go to schools, as Kelly mentioned, kind of in silos. That's gotten better, but it's still true. And so we need time for our teams to really practice working together, and simulation can provide a really powerful way to do that. So what we want to be is kind of like a pit crew, right? If we're running a resuscitation, I want it to run as smoothly as this. Everyone knows their role, knows exactly what they are supposed to be doing, knows what their teammates are supposed to be doing. It happens seamlessly with great choreography. Can't argue with that, right? And so in a lot of circumstances, healthcare teams do resemble pit crews, particularly when we are talking about operating room teams, emergency center teams, ICU teams, where they are resuscitating patients. They're having to respond suddenly to an emergency. And so those are really complex systems. When I'm in the emergency room running a code, there may be 20 to 40 people in that room who all have unique expertise that I need to utilize to take care of that patient. So hopefully we have practiced ahead of time, right? We need to be able to be coordinated, we need to communicate, we need to anticipate the unique aspects of that patient's care, right? And so we need to practice that and practice it together. This is just one example of that. This is our obstetrics and gynecology team practicing for massive transfusion protocol. So this is when a pregnant woman hemorrhages, typically during labor or after birth. and we very rapidly can really lose all of their blood volume. So we need to have a very fast, very coordinated response to save that mother and baby. And so this team does these scenarios every month. They do it in the OR, in their actual space, and practice literally what provider is standing where, right? So I'm in zone 1 and I'm going to be doing this. I'm in zone 2 and I'm going to be calling the blood bank, and that's my role for today. So they know those things, they practice them over and over again. In traditional simulation, one of the things that we do is we run a scenario, the whole thing, whatever it is from beginning to end, and then we debrief. And we always sort of say, hey, you know what? The debriefing, where the team talks about it, understands what went well, what didn't go well, is the time when the most learning happens. And that certainly is really powerful. But if we take this pit crew analogy, some of it is we need to practice over and over again, right? We need to do something called deliberate practice, right? Until we do it right? So sitting around after a scenario and saying, well, gosh, next time I should really do this first or that first or those kinds of things, is a little unsatisfying, right? And so our group has been involved in the sort of the forefront of this novel technique where we design scenarios so that teams do them over and over again in progressively more challenging rounds so that they practice again and again, all right? And it's a lot more like coaching, right? If you're a coach standing on the sidelines of a baseball field, right, and you see a hitter doing something that's not right, you're not going to ask them, well, what did you think about that? You're going to tell them, hey, I think you should try it this way next time. And then you're going to have them do it again, right? And do it again until they're doing what you want them to do, right? And so for things where we really know the answer, but we know that it's challenging team choreography and communication, we use this rapid cycle deliberate practice methodology. We do this in the emergency center, here in the center, and many other places. With this, the team practices the basics, the first few minutes of that scenario, over and over and over again. So they are going to get that down perfectly, right? They get the more advanced rounds less frequently, but we can engage them over and over again on those as well. And so that way we know that our teams have thoroughly practiced and practiced in the right way, right? We don't want to teach something in simulation or have people come away from simulation thinking that they didn't get it right. And so we want them to keep going until they have been able to get it right. Another example for communication is our simulation per patient and family experience. This uses simulated actors. They play both parents and they also play team members. And what this allows our clinical managers to do is to practice having sometimes those challenging conversations with a family member who's unhappy about some part of the care that they've received. So they get to practice interacting directly as that unit leader and how would they interact with that family, and also practice providing feedback to the bedside nurse that had been dealing with that family, right? So that again, we can help everyone learn better communication skills. These again are videotaped. People, they watch them afterwards and they're debriefed. You get to see yourself on camera, which of course is no one's favorite thing, but really important. All right. We also do a lot of simulation-based outreach, and Kelly referenced some of this, but I want to talk through a couple of the courses that we do. The first one that I'm going to spend some time on is simulation for our families and caregivers who are going home with children with special medical needs. The second one that I'll talk about in a little more detail is our simulation for the Houston Fire Department. And then I just want to mention, we are working on a program to start doing outreach to community EDs. Statistically, about 90% of children's emergency center visits are to non-pediatric emergency departments, right? That means you might be seeing a general emergency medicine physician, you might be seeing a family practice physician, but your child won't be seeing a pediatrician or a pediatric emergency medicine specialist like they would if they come to a children's hospital. So we need to make the care that they provide there better. And one of the ways that we can do that is with simulation. So we're working on a program to develop that. We have a very active simulation program for our school nurses out in Katy. And so with Katy ISD, we do simulation again for some of the medical emergencies that school nurses may encounter during their time. And finally, lots of non-TCH learners for a number of our courses, and we're working to grow and develop that so that we really are the place where people come to for pediatric education. So talking about family and caregiver education, you guys are going to see this on your tour, but every week, really, and oftentimes many times a week, we discharge patients home who are going home for the very first time with a new tracheostomy, so an artificial airway that they may need because of airway abnormalities, or they may need because they are chronically on a ventilator. As a physician, I can't even imagine what it's like to take care of a child in my home with those kinds of medical needs. But these families are trained to do so at the unit, at the bedside. They learn all about the routine care that their children need, right? But what we also want to do is make sure that they are ready to respond in case their child has an emergency. And as you can imagine, an emergency with a tracheostomy requires a very rapid response, right? If you lose your airway, you are not going to survive for long unless someone makes the right interventions. And so we bring the families before the patient is discharged. They're one-on-one training with a physician and a nurse. They come up here and they go through several, 4 or 5 of the high fidelity scenarios on the mannequin, right, which they wouldn't be able to practice on their child at this moment because their child isn't having their trach fall out or get obstructed or things like that. But in the simulation, they can practice it. They can practice when am I going to call for emergency help, what else am I going to do, all of those kinds of things, so that they can feel much more comfortable going home. All right, and this is something that is just continuing to grow. We'd like to really expand this to other high-risk patients as well. So things like children with complex seizure disorders, other technology dependence, right? Cardiac emergencies for some of our high-risk cardiac patients as well. And we're working to create really increased capacity to do that. There's lots of logistical challenges on how we can make that happen for parents who are juggling lots of things, but really important that we make sure parents who are taking home children with special healthcare needs really feel comfortable knowing how to respond not just to their day-to-day needs, but to possible medical emergencies that can happen. All right, the Houston Fire Department. So, paramedics and EMTs are probably the most amazing people out there, right? They are just wonderful people, but they don't see sick kids very often, right? So there aren't that many really critically ill pediatric patients, even in a big city like Houston. When you distribute it out amongst the number of paramedics and EMTs that we have in the city of Houston, most of them won't respond to a critically ill patient even every year in pediatrics. Adults, they absolutely will. They're very comfortable with adult critical care, heart attacks, strokes, all of those kinds of things. But pediatrics makes them a little more uncomfortable, right? But yet we know how incredibly important it is that they respond when there is an emergency and that they initiate care immediately, right? And so high risk, low frequency events are kind of the perfect thing to teach using simulation, right? We can immerse them in a realistic scenario using their own equipment and really teach them about pediatric skills. So this was a collaboration with the City of Houston that began about 8 years ago. We started talking about it. We've been teaching the course for about 6.5 years now. And I say collaboration, the reason this fuzzy picture is up there is that blonde head that's leaning over a mannequin there is former Mayor Anise Parker, who visited the Sim Center as she was supporting this course. What we do, we bring teams from the fire department to the Sim Center 2 days per month. They do simulations in their actual teams. So basic life support providers will respond first. That's how our system works in Houston. And it's what's called a tiered response. And so we have them enter the scenarios that way. And the BLS providers do what they can, and then the advanced life support providers arrive secondarily, just like what would happen in real life. We do skills stations, we do high fidelity scenarios, we have a pediatric assessment lecture where we talk through some of the most common pediatric emergencies and things that are different about kids than adults. We team teach this with Houston Fire Department. So we have fire department instructors that we employ to help teach this along with our emergency medicine faculty. That way I'm not telling them stuff to do that's not within their scope of practice. And we are collaborating to really provide a great scenario. I said that the fire department is an amazing group to teach. Okay, we put them in scenarios where we set up our sim rooms to be out of hospital, right? So we set it up to be a baby nursery. We set it up to be a twin newborn delivery, that top scenario, home delivery, babies on the floor. And they lie down on the floor and take care of those babies. They intubate, they do everything else that they need to do. And that's one of the reasons I say I think firefighters are just really amazing. So we have a trauma scenario where we set it up, it looks like it's, you're on the highway, and then we play highway noise in the background so they have trouble hearing, right? Things that are real. We use their real equipment. So unlike hospital-based providers who are used to working out of a crash cart, things like that, EMS providers basically carry everything with them. And so when we dispatch them to a scenario in the Sim Center, we do the exact same thing. You better check your bag. If you don't have your equipment, that's what would happen in real life, right? So what would you do? So you better check your equipment. Right. And then we team teach those debriefings. Clinical rehearsals are a little different. So we have some really unique patients at Texas Children's, right? And sometimes they need procedures that are so unique and different and, specific to that one patient that we need to actually practice it ahead of time. The perfect example of this is our conjoined twins. Okay, and we've had 2 sets of conjoined twins over the past several years, both of whom have had multiple simulations done for them at various stages along the way. First and foremost, we've done simulations in our neonatal intensive care units to practice how would they actually resuscitate those patients while they're still conjoined, right? They may have difficult airways, they may have varying pharmacodynamics as far as, if you give twin A the medicine, will twin B get some of it or not, right? And so there's lots of things that the teams have to work through well before they're talking about surgical separation, right? Then many of them go through a very staged process for surgery, and we've done simulations for those different stages. So first stage is typically putting in some kind of tissue expanders so that they have more skin available to them when they subsequently do the closure. And so we've done scenarios for that. And then finally, this is a picture of our simulation of the actual separation. As you can imagine, this separation and this particular set of twins were joined at the chest. So their surgery involved specialists from about 6 or 7 different surgical subspecialties, as well as our anesthesiologists and all of our OR support staff, et cetera. Incredibly complicated, prolonged surgery was planned. Lots of surgical planning going on, but ultimately the teams needed to practice before they actually went through it. Now, obviously we can't practice some of the technical skills that the surgeons are going to do when they get deep into that anatomy. That's not part of what we were able to do, but what we can do is talk through every step of sort of how are we going to prep and drape these patients and hold them? How are we going to control their airways? Which team is going to be present right now? When are we going to activate the next team, right? And go through all those steps and stages. How are we going to communicate with the family during the surgery? How is that going to happen for such a prolonged event with so many different subspecialists going through, right? And so we spent a Saturday, a full day, going through all of those different stages, and then they had the surgery about a week later. All right. Next thing I'm going to talk about is simulation really as a quality improvement tool, right? So we talked about it, we do lots of education. Absolutely, that's fundamentally important. But what we've also learned is that simulation can be really powerful for helping us to improve systems, to understand how our systems work, okay, to make them better, okay? And so human factors, right? So we build these beautiful hospitals, right? But do we really know how they're going to work before we build them? Have we really thought about how real people are going to do procedures and do patient care in those spaces before they're built? Or we may just develop, it may not be a new building, but it may be a new process, procedure, and everybody sits around a table and says, this process sounds great, right? How many times does that happen? You send it out to implement it and everybody's like, yeah, that's not going to work, right? So again, how can we use simulation to test those things before we put it in place for real patients? So we're really focused on, in these kinds of simulations, identifying latent safety threats, things that could hit a patient, but we want to prevent from hitting a patient, right, and creating a problem. So it might be physical design of a space, right? It might be missing equipment or setup, but it also might be insufficient personnel, right? So we run virtual units where we actually really test that kind of thing. I'm going to focus on our legacy tower. If you guys haven't seen the legacy tower, it is an amazing space and you should go over there. Kelly referenced that we did pre-construction simulations. So that was starting a number of years ago before they even started building, where we built out rooms and tested the design, and I'm going to show you that. And then we did several phases of post-construction simulation, including next week where we're going to be testing the helistop, which opens next month. So I'll show you a little bit about that. Multidisciplinary, we involve everybody in these, right? We want to know what infection control thinks, what security thinks, what all of the frontline clinical staff think. Okay. We focused for the pre-construction really on what are best practices for how is a hospital supposed to be designed, how does it work best, right? And how can we base what we're doing on this? So you can see the warehouse truly built out as the rooms had been designed by the architects, right? Equipment, supplies, personnel, actual scenarios of taking care of patients in the warehouse so that we could figure out, hey, is this room space big enough? What happens if we have to bring this piece of equipment in? What are we going to do in those kinds of cases? All right, and then the team debriefed. Okay. Lots of recommendations came out from these debriefings, okay, including some things that were really able to be tested right in that space. So this was the initial design of the nursing alcove for the ICUs, and you can see that there's 2 computer monitors that are vertical, as well as you notice just the window sides into the rooms, as well as where our personal protective equipment is. Team made some recommendations for changes. And so the personal protective equipment was moved to facing out so it would be easier to access for teams coming in during an emergency. The windows were made larger, and those monitor screens were moved so that it was obvious which monitor went to which patient. Sounds simple, but wow, that's really important. So lots of changes were made based on those. So then, fast forward a couple years, and we have this beautiful new building. And we went and did lots of simulation in all of the different new spaces that were opening. Phase 1 in April, phase 2 just this last month. And we tested many different things. At this point, we were much more focused on how is this new beautiful tower going to function as individual units? How is it going to function in connection with the rest of our hospital, right? And making sure that all of those ancillary support issues that are so important are addressed. So rapid response and codes, patient transport to different areas of the hospital, within ICU issues about communication, teamwork, that OR and MRI space, support services, and then family involvement. And we specifically involved people from our Family Advocacy Council in this, who actually were participants in the scenarios. They played family members, and they provided the family perspective in all of the debriefings. So they could tell us, you know, as a parent, this room is beautiful, it's got a couch, it's got all this stuff, it's great, but you know, I really felt trapped in the corner when the team came in and was doing procedures on my child's, right, for example, and could give us a lot of their family perspective. So just to show you some pictures, we went through the PACU, so the anesthesia care areas, the ORs, beautiful new OR spaces with lots of wonderful technology, an OR MRI suite. So this allows our neurosurgeons to get intraoperative MRIs. As you can imagine, MRIs, right, magnetic, lots of surgical equipment, not compatible with MRI. And so we did lots of simulation and safety testing in those spaces to work through all of their safety checklists, handoffs, communication, and the plans for how they would do that. For our ICU settings, for both our pediatric ICU as well as our CVICU, we ran what we called a virtual unit. So we made the team take care of 10 patients, right? Some of them were just having routine days in the ICU. Some of them were having decompensations and worsening. We wanted to experience that full spectrum of patient care in the new space. Transport, as you can imagine, right? Transport between Legacy Tower and our West Tower is really important, and we needed to work on that. So we did a lot of that. And I mentioned the family presence, which was really critical. We use something called failure modes and effects analysis. The idea behind this is that healthcare systems should proactively look for those latent safety threats so that we can prevent them in real life. You don't have to use simulation for this, but we think it's a really valuable method because, again, it gets people in the space, in the environment, using the processes, as opposed to just sitting around a table and brainstorming. And so we prioritize our findings, and the findings from the simulations go back to the clinical leaders so that they can work on them before the opening. We do lots of other systems-based testing. Some of these have included things at our West Campus for sleep lab, working on improving access to sleep studies, which is really important for our patients and has been a big backlog. ECMO, which is extracorporeal membrane oxygenation, so artificial heart-lung bypass, okay, is a very complicated team system, and so we do simulations for that. And we've recently done some simulations for spine surgeries at the Woodlands, which will be opening shortly. So as a new process comes on board, we want to be able to make sure that the system is ready for it. Okay, I'm going to finish up talking, and we're going to get you guys on your tour. I want to tell you one last story about a patient who I think is really a classic, typical Texas Children's patient, the kind of patient who needs us, right? So this is an 11-month-old who was born with Smith-Lemli-Opitz syndrome. That's a complex syndrome that can have variable penetrance, but in this child's case, he was pretty severely affected. He had a small head, he had microcephaly, a cleft palate, very low tone, was fed via a gastrostomy tube. And he came to our ER with cough and vomiting, respiratory distress, trouble breathing, and was supported by sort of progressively increasing invasive methods of support, was admitted to our ICU. When he was admitted to our ICU, they were concerned that he was going to need to be put on a ventilator. That would require placing a breathing tube, which for this child had previously been difficult. So he'd been labeled as a difficult airway. Okay. So our ICU, very appropriately, was trying all those non-invasive methods. That didn't work. They called our anesthesiologists, which is what they should do. So our critical care doctors can absolutely intubate a routine patient, but for a high-risk patient, they're going to have our anesthesiologists there as well. They did that. Neither of them were able to intubate. This is a really critical situation then, because we have a child who is not breathing well, and now we cannot visualize and take over their airway. They called our ENT team. They brought surgical airway kit to the bedside. So this is a big cart that has all of the equipment that ENT needs, in fact, to do a tracheostomy if needed. Our ENTs at bedside were actually also unable to visualize the airway. This is truly a medical emergency at this point, although thankfully we were able to continue to bag mass ventilate this child, at least for the time that this took. So he was taken to the operating room, and he had a stat tracheostomy placement. Okay. He actually did really well, but this is an unusual event, even at Texas Children's, that it goes sort of that far along that nobody can get this endotracheal tube. And so the reason I tell you this is because that happened on May 22nd. And May 22nd was the day that Legacy Tower opened and all of our ICUs moved. And so there's lots of reasons that that went well, you know, talented providers, all of those kinds of things, but the system worked well, right? And the system worked well for lots of reasons. Again, clinical leaders on the front line were doing all that they could to plan for those new events. But one of the things that we did is we had simulated those events, right? That was one of the scenarios that we had done both in our ICU as well as in our operating room simulations just a few weeks before opening Legacy Tower. And the clinical leaders really came back to us and said, you know what, we are so glad, right? Because this really made such a difference for this patient and for the teams who knew this is how the system is supposed to work and were able to make it work in this critical situation. So with that, Kelly and I want to thank you for all of your attention, and we would be happy to answer questions. We'll call it a debriefing because that's what we do in simulation. We'd be happy to answer any questions. We'd also be happy to get you guys set to go on the tour so that we can show you, in fact, what we do.